Hi guys, it's Dr. Shelley, and we are talking about solutions, fluids, IVs, central lines. And so if you are a nursing student, here's where you just want to take really good notes on regular paper. If you are my NCLEX student, then you know that we are on the section of your procedures packet. And again, what color is this? It's pink. It's on the test. So we're going to go into the midlines. So if you look up here, everyone, I did a comparison. Midlines versus central lines. We know that midlines are not central lines. So if I could stress anything, midlines are absolutely not central lines, because the definition of the central line is that the tip sits in the superior vena cava. This tip, the tip of a midline, and it's very long, it's 3 to 8 inches. The tip of this midline IV sits in the axillary area, not the superior vena cava. This is a central line, this is not. However, it is quite an amazing peripheral IV that the LPN cannot insert, because the limit for insertion for LPNs is a catheter, an angiocath, that is 3 inches, okay? So the LPN cannot insert this particular IV. You do need ultrasound guidance, but you don't need an X-ray. These are extremely common because you don't need an X-ray confirmation. They're extremely common in long-term care facilities. And when you give that handoff report and you're going over the patient's status, it should be at the bedside. And one of the things you should be doing during your handoff report is going over every line they have. What kind of line is this? What kind of gauge is this? Just communicating about the lines. I've seen people get report and they didn't even know there were some lines in their patient. That's kind of ugly. So we don't need a confirmation with an X-ray. This is an amazing IV because it can go on for months. It is absolutely optimal for the patient who would need IV antibiotics more than 7 days. And who am I thinking about? Because certainly by now, all of you know that when we talk about a patient needing IV antibiotics for more than 7 days, well, that could be a patient who has osteomyelitis. As you know, if they have osteomyelitis, antibiotics through the PICC line would be perfect, because you can give it for the next 3 to 4 weeks, which is when it's usually ordered for. The patient is really given a little bit of freedom because it is still a peripheral line, but it is just so nice to have this line so the patient does not get poked over and over and over again. Now, just a reminder, adult patients get an 18 gauge angiocath. If they are elderly, you can kind of break the rule and do a 20, but 18, 16, those are the gauges for the patient, specifically an 18 gauge angiocath IV for this peripheral line or any other. The other thing is, we said we're checking that IV site every single hour. We're looking specifically for oozing at the IV site. Now, if we go a little bit further into details and we go and we're done with this whole midline business and we realize it's not a central line because the tip sits in the axillary area versus a central line where the tip sits in the actual superior vena cava. There have been many times when the nurse didn't even realize that they had a central line. So let's clarify some things, shall we? Let's make sure we know that anytime a patient has a TPN, it is a central line. Let's make sure we know that anytime a patient has a PICC line, it is a central line. It's a peripherally inserted central venous catheter. Okay, so it's peripherally inserted, so it's up in here somewhere, but it's still a central line because the tip sits in the superior vena cava. We must remember triple lumen is a central line. We have to remember that metaports are central lines. So the patient that gets a temporary Quinton catheter has a central line. Now, central lines are really risky but they're very necessary. You can do everything with them. You can do hemodynamic monitoring. You can do frequent blood draws. You can do patients that need blood. We can throw chemo in there. This is where we put our medications when they are so vesicant that their osmolarity is very much over 500, or the pH is less than 5 or greater than 9. This is the perfect vehicle, if you will, to take those drugs to the patient. So really vesicant drugs like vancomycin, dilantin, multivitamins, and I wrote a couple of those drugs down just because they're pretty popular for causing trouble. Again, vancomycin, potassium chloride, multivitamins, dilantin, those are the big ones. Levophed, dopamine, those need to be in a central line. It's just optimal for your patient, okay? Now, so let's review a couple things. I will tell you right off the grip that anybody with a TPN, you have 3 labs to follow. This TPN is made in the pharmacy, and it's going to be based on the labs that the patient has, so it's very individualized. So the pharmacist is going to make up that TPN bag, and it's usually like a clear yellowish kind of bag. It's clear, you can see straight through it. If it's tan, brown, foggy, cloudy, send it back and hang D10W to get your bag back up. It's a good substitute. This TPN is all about nutrition. So of course we need to follow the nutrition lab. What is the nutrition lab? Well, a nutrition lab that you better follow is to check the patient's albumin level. Because the albumin level is going to give you an idea of how, malnourished your patient is or is not, right? But then the other issue is if it's a nutrition bag, if it is temporary parenteral nutrition, TPN, or actually total, it's not temporary, forgive me, total parenteral nutrition, if it's total, it has everything in it. So it even has sugar in it. Uh-oh, that's a good and a bad thing. Because if it has sugar in it, then I think you know that we're going to have to check the blood sugar every 6 hours. Because in a patient with a TPN, that blood sugar can go way up, and now we've got a DKA or HHS patient based on that TPN hanging. All right, let's keep going. You know who else loves sugar? Bacteria. So a TPN is an invitation to every bug in your hospital, like MRSA or VRE or anything. And so we want to monitor the patient's white blood count and make sure that we are watching that doesn't go too high, because this patient could easily get an infection. The TPN is non-tunneled. So when we talk about complications of IV therapy, whether it's phlebitis, infiltration, extravasation, or bloodstream infection, this guy is at risk for a bloodstream infection because of all that sugar. So you're going to have to monitor your 3 labs. You're going to have to watch this person very closely. Now, if we look at the next central line, it's called a PICC line. It is the favorite line of the day. Everybody loves it because you only have to change the dressing every 7 days. It can last up to a whole year, and we can put almost anything in it, but there's not a lot of risk with it in terms of a patient getting an air embolism. Why is an air embolism not a risk? Because an air embolism is a risk for a central line, but it's not a risk for this central line because air embolisms are pretty much seen more so with the closest you get to the peripheral line, closest you get to the heart. So this has a risk of an air embolism, but not as much as your jugular, your subclavian, blah, 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 right? Now, here's the one that there's no risk at all. There is absolutely no risk of a pneumothorax. And you know why. I always teach you the same thing. I remind you that a patient that has anything done between my clavicles and my sternum, anything done, is at risk for pneumothorax. Whether it's a central line insertion into the subclavian area or even the jugular area, but mostly subclavian, whether it's a liver biopsy, a thoracentesis, whatever's done in this thoracic region, a CABG, a patient with valvular repair, any of those things that is done, those things that are done in the thoracic area, put the patient at risk for pneumothorax. But you're peripherally inserting this catheter here, so you don't have to run the risk of the pneumothorax, okay? Now, it is non-tunneled. What did I say non-tunneled meant? Here we go. At risk for bloodstream infection. So any non-tunneled central lines put the patient at risk for a bloodstream infection. Now, let's keep on moving. The most common central line seen in the hospital is going to be the triple lumen. It has a dressing change that typically is every 48 hours. It is very short term, a week. It's for your ICU patients, and you get the patient together, discharge them, take out the triple lumen, the central line. Again, non-tunneled, at risk for infection, okay? See, think of it. If I'm in a tunnel, then the bugs can't get to me. But if I'm all outside the tunnel and, available, then the bugs can get to me. It's that simple. Next, you can see these metaports. A metaport is going to last for years, like forever and ever, right? And so you do have a few things you have to remember. You need a Uber, H-U-B-O-R, an Uber non-coring needle. And again, NCLEX students, you have a pink packet that says all of this. You need to remember there is no exit site, so there's no need for a dressing change. You need to remember that this is tunneled, so there is no outrageous risk of a bloodstream infection. It's tunneled. It must be surgically placed, and to get rid of it, the surgeon has to take it out. You must get a blood return when you're dealing with this type of central line. You do have to get a blood return. Okay, so again, this is your whole, metaport or whatever. Portacath, a lot of times you'll hear that language. Now, I have a couple things at the very bottom. You'll see it says a Quinton catheter. A Quinton catheter is non-tunneled, temporary, short-term, for dialysis. It would be called continuous renal replacement therapy. We use this in the ICU very often for patients who are dialysis patients and they clot off and we can't get their fistula or their graft to open up, and it's like, oh Jesus, we better get this guy to the ICU or the emergency room to get their dialysis. Now remember the rule with these dialysis patients, and this is true across the board. Red ports are arterial, which means away from the patient to the dialysis machine. Blue ports are venous, which means venturing back to the patient, venous return. So it's from the machine. You cannot mix up these ports. If you're blessed enough to have another type of central line for dialysis and you have that whole purple port, that is where you can do a lot of different things with that port, medications and whatnot. So that's that. Now, in the last 5 minutes, we have our complications. Number 1, phlebitis. This is where I see people screw up a lot. And I'm going to come all the way over here and I'm going to show you this mnemonic of STRAW. And STRAW is the mnemonic for infection, inflammation, and DVT. So come with me. STRAW. STRAW is S for swelling, T for tender, R for red, A we'll talk about, but W for warm, okay? Now the A, it depends on what the problem is. If it's a DVT, then this A stands for anticoagulant. If it's an infection, then the A stands for antibiotics. If it's simply inflammation, we would say anti-inflammatory. Okay, now we don't use any anti-inflammatory for this patient, but the straw mnemonic works here very well. Now I don't really care which one of these your patient has. Stop right now if you think you're going to let this thing stay in, because every single one of these says, take it out, take it out. And just in case you were real confused, we know doggone well you gotta take that out, okay? Now, so let's go up here and talk shop. The number one error that I see with nurses is they confuse these two. The patient has phlebitis. If you see straw, it has to be red. It has to have swelling. It is warm to the touch. You took it out, and what did you do after that? You put the warm compresses on it. This is the number one error. I see nurses putting cool, and they just caused a big problem. Because if you have phlebitis, you want vasodilation so that you don't get a clot in there and it becomes thrombophlebitis. You need the blood to keep on moving through that vein, even though it's now inflamed and damaged. You don't want the blood to get caught up because you put a cool compress, because cool vasoconstricts, closes up the vein even more. Now blood doesn't move as readily through it. So again, warm compresses elevate the arm. How do you know it's phlebitis? Oh, you'll see a cord, you'll see ropiness. The flow will be very sluggish, red streaks, and can lead to thrombophlebitis. Big deal here, okay? Now, infiltration. Oh, it's just the opposite. This one is cool to touch, but you're still gonna take it out. The cool or warm compresses might feel good. It depends on what you think and your patient feels. It doesn't matter with this one. It does matter with that one. It does not matter with this one. However, you want to elevate the arm. How do you know that it's infiltrated? Oh, it's going to be mottled with different coloring. Going to have blanching. There's going to definitely be fluid leaking around it. And you're going to see cool skin. I really tell you to just feel it. You'll know right away which one it is if you just feel it. What does it really mean? Well, it means that when you inserted the IV, maybe you took the tip and kind of went into the vessel wall. It means it became dislodged and pierced the vessel, and now it's letting fluid go into the interstitial area. It means that it wasn't anchored good enough, taped down, anchored, and now it's everywhere doing its thing. The worst thing that can happen with your patient is that infiltration that just occurred with a drug. So extravasation, watch this, infiltration of a vesicant drug. What is the definition of vesicant? An osmolarity greater than 500 or a pH less than 5 or greater than 9. What is it that you want to use in the event that that happens with many drugs? Phenylamine, which is Regitine. That is like, it's not really an antidote, but it's the treatment. I call it an antidote, but it's really the treatment. It causes vasodilation. It prevents necrosis of this vessel. And it is excellent for extravasation that is caused by vancomycin, levophed, or dopamine. Again, people, check your IV site every single hour. Now, you can alleviate some of this, especially this, by making sure you put the IV on a pump. This one, you really just have to watch it, and you have to be very clean in your technique, aseptic technique, because you're putting in an IV. Remember, no more than 2 sticks. You cannot poke people more than twice. That's a big deal. Peace out. Until next time, Dr. Shelley signing off.